Good morning everyone, and welcome to this very special In Conversation event about the Royal Children's Hospital Cardiology Department. My name is Sue Hunt and it's my great honour and privilege to be the Chief Executive Officer of the Royal Children's Hospital Foundation. I'd like to begin by acknowledging the traditional owners of the land on which we're gathering today, the Wurundjeri people of the East Kulin Nation, and pay my respects to elders past, present and emerging, and acknowledge any Aboriginal people who are with us today. And I'd like to start by saying a huge thank you to everyone who's tuning in for today's event. In particular, I'd like to welcome the RCH Foundation board members and staff, RCH board members and staff, members of our incredible donor community, including individuals who have committed to or who are thinking about leaving a gift in their will, our community supporters, who we call our RCH champions, our major donors and philanthropic partners, our trusts and foundation supporters, our bed sponsors, our corporate supporters and workplace givers, and our Children's Tree supporters who are our monthly givers. I'd also like to welcome members of the RCH 1000 who support research here at the hospital campus, and members of our auxiliaries network who, of course, for over 100 years have been supporting this great hospital. So, on to today's proceedings. You're going to hear from a group of our esteemed experts who are each going to shine a light on various parts of the incredible work of the cardiology department. And it's my very great pleasure to welcome Professor Michael Chung, who's Director of the Cardiology Department, Dr Ben Davies, who's a consultant cardiac surgeon, Dominique Morsman, who's a clinical nurse consultant, and Artressa Ng, who is also a clinical nurse consultant. Thank you all so very much for being here. In today's In Conversation is all about the department, as I say, and it is the largest paediatric cardiac centre in Australia and is a leader worldwide in cardiac care. The department is also home to the National Paediatric Heart Transplant Centre, caring for patients who need heart transplantation from all over Australia. Today, our speakers will touch on projects past, present and future which have been made possible by philanthropy, including some incredible research that's being undertaken by the team, and also how education in advanced heart failure nursing is improving patient care at the RCH. You're also going to meet Noah, who's been one of our hospital's extraordinary cardiology patients and a great success story. So now, in this In Conversation event, you'll also have the opportunity to ask questions of our guest speakers. So please feel free to type your questions into the chat box at any time and we'll capture them and we'll get to them a little bit later after all our presentations. And you should be able to see the chat box in the menu along the bottom of your screen. We're also doing live captioning for the event, and these captions are automatically generated, so they may not be perfect, but we do hope they're helpful to some of you who might need them. And you can access those by clicking the live transcript button from the menu along the bottom of the screen too. So now it's my great pleasure to introduce our first guest, Professor Michael Chung. Michael attended medical school at the University of Bristol before training at world-leading congenital cardiac centres, including the RCH, Great Ormond Street Hospital in London, the Royal Brompton Hospital in London, and the Hospital for Sick Children in Toronto. We were very lucky that he returned to Melbourne in 2005 as a consultant cardiologist. And in 2011, Michael was appointed Director of Cardiology at the RCH and leader of the Heart Research Group at the Murdoch Children's Research Institute. We were delighted that through RCH 1000 we were able to support Michael's appointment in those areas. He's also currently the chair of the Paediatric Executive of the Cardiac Society of Australia and New Zealand. So Michael, thank you so much for being with us here today, and over to you.
It's a pleasure. Thank you very much, Sue. The scale of the problem, how many children are born in Australia and New Zealand each year? Our last figures from about 2018 show that it's just over 300,000 if we include New Zealand as well. It's a total of 373,000. Now, we have a registry with the Australian New Zealand Paediatric Intensive Care Society, which tracks all cardiac surgical operations performed in Australia and New Zealand. And for that year, there were just under 2,800 surgical operations. The results in Australia and New Zealand are incredibly good on the world stage, and our overall mortality is 1.4%. Despite that, however, heart disease remains a major cause of death in infancy, and that's a reflection of the incredibly high standard of healthcare in Australia and New Zealand. But other things like infectious diseases and perinatal mortality rates are very low in comparison. So how often do children have heart disease, and what forms of heart disease do they have? You know, when we talk in the community, the types of heart problems that most people face are because of ischemic heart disease, heart attacks, high blood pressure. Whereas our kids, our patients that we look after, it's more often likely to be a congenital heart problem. So a structural heart problem is the main types of patients that we look after. And it's about 1 in every 100 babies is born with heart disease. Now, thankfully, not every one of those children with heart disease needs treatment. But at the Children's Hospital, we perform around 1,000 operations when we include our cardiac catheter procedures as well as our cardiac surgical procedures. This accounts for about half of the paediatric intensive care patients on the ward at any one time. And within our cardiology clinics and our wards, we perform more than 16,000 heart scans, echocardiograms each year. As Sue said, we are the nationally funded centre for heart transplantation, so the vast majority of children and adolescents who need heart transplants will come to us from around the country and also from New Zealand. This equates to about 8 babies in Australia born every day with heart problems. Now, Australia, as you know, is a very big country, and most of our population is around the coastline. In 2021, we estimated there were about 6 million children in Australia. We are located, see down the bottom there. We look after all children in Victoria, South Australia, Tasmania and the Northern Territories. The majority of children in Northern Territories will come to us for cardiac surgical procedures, high-level cardiac care. And that will equate to about 1/3 of all Australian children. The RCH strategy, which is just being developed and is being discussed, is threefold. We intend to be a leading paediatric academic hospital. We intend to have an integrated paediatric service system throughout the state. And we have a long-term goal of having healthy children and young people in the community. Now, all 3 of those elements of care and what we intend as a leading children's hospital obviously need to form a part of how we're leading in cardiology too. And I'll show you some of the things that we're doing at the moment. As part of the Melbourne Children's Campus, we work very closely with the Murdoch Children's Research Institute and the university. And when we think about those 3 partners, we can see how some of those responsibilities, they're not exclusive, but we all play a part in clinical care, in research, and in education. Foundation support of the cardiology department has been with us, thankfully, for a long, long time, and we have multiple donors to our department. And when I say our department, it's cardiac services in general, not only cardiology alone. We have donors who've given to cardiac surgery, to our perfusion teams, to our cardiac nurses, for our trainees. So there are lots of different people who have benefited, not alone, notwithstanding patients themselves. And that funding has gone to support research, education and equipment that we have thought to be important in the care that we're delivering. Clinical care, as you can imagine, in the hospital is of utmost importance to us. This is just a few pictures of some of the patients that we look after, and Dominique and Atressa will talk more about this. This device on the right-hand side, you can see the movie, is something called a Berlin heart support system, and you can see this pulsating membrane which is delivering blood to the patients, and we'll see more about that later on. For our department to provide these services, obviously we need to think about how we provide leadership, education and training. As services have become more complicated, it's very important for us to build our people and our teams. Up until about 2005, I think we had 2, maybe 3 local trainees who had decided to embark on a course, a career in cardiology. Since that time, we get about 1 to 2 people per 6 months applying locally to become cardiologists, and we have built the team from local trainees over the past 10 years. The majority of our cardiologists are now from Australia. No team can function, though, with just a single craft group, and it's important that we give career opportunities not only to doctors and medical staff, but also to our nursing teams too. And you'll hear from our clinical nurse specialists and CNCs about how nursing care can improve the delivery of care to our patients. And a little bit about research in a second with Ben. We'll talk a little bit more about his research that he's been doing. But some of the research that we have carried out over the past 10 years with support from the foundation, one thing is looking at heart muscle injury. When our surgeons operate, unfortunately, we have to stop the heart, we have to stop the lungs during that period. And unfortunately, the heart-lung bypass machine will cause some heart muscle injury. And in a research project supported by RCH Foundation, we found that a test drug which we were employing at the time of bypass reduced the degree of heart muscle injury by 40%. These nice images on the right-hand side you can see here are just some of the advanced imaging techniques which we can employ using MRI scans. Those little tracer lines that you can see are tracking blood particles as they're moving through the aorta, which is the main blood vessel supplying the body. You can see when there's a narrowing there, those streamlines become very, very close together, and where it becomes dilated and more bulbous, that flow profile becomes very, very disturbed. And what we're seeing there is loss of energy, and things that we can do to minimize that will optimize blood flow. That again was supported through some software which we were fortunate to acquire through foundation support. So, as I said before, the 3 things that we can think about in general are boundaries of clinical care, how we can continue to improve that, the people support that we need to deliver that clinical care, and some of the research that we can use and develop to answer some of the questions which are troubling us. Thank you very much.
Thank you, Michael. A really insightful presentation. I think covering, as you say, those areas of clinical care, which included equipment that can really support it, people development, and of course research. And I think you painted a great picture. Thank you so much of how our generous donors have been supportive of cardiology and cardiac care here at the hospital. So just a reminder, if you have any questions for Michael, pop those in the chat right now, and we'll get to the Q&A session later on. So now I'm very delighted to introduce our next guest, so Dr. Ben Davies, who graduated from medical school and completed general surgical training in the UK. He then undertook PhD studies at the RCH and the Murdoch Children's Research Institute here in Melbourne, and he looked at the potential role of stem cells in improving heart function. He then returned to the UK to enter the West Midlands Cardiothoracic Surgical Training Program. After additional fellowships in paediatric cardiac surgery at Birmingham Children's Hospital and Great Ormond Street Hospital in London, Ben was recruited as a consultant by Great Ormond Street Hospital. He undertook paediatric cardiac surgery and adult congenital cardiac surgery, and he later became the surgical lead for paediatric heart failure and transplant program. Once again, we've been delighted we've been able to attract Ben back. He returned to Melbourne in 2021 and he joined the cardiac surgical team here at the hospital. So Ben, over to you.
Okay. So thank you, Sue. So I'm Ben Davis, one of the four cardiac surgeons here at RCH. And I wanted to talk about a project that was funded by RCH Foundation many years ago, just over 15 years ago, and that's been continued in my absence and has just recently finished. So we wanted to target one of the low-hanging fruit, one of the highest risk patients. We've heard about the all-comer mortality, about 1.4% for all cardiac surgical operations here at RCH and within Australasia in general. And I wanted to touch on repair and renewal. If we think about vertebrates, we think about different species and also different ages of people. So if we think about a newt or a lizard, we know about their ability to lose a tail and to regrow it. At the other end, Beatrice there, who's 100, has had by some means very lucky genetics, and she hasn't died despite smoking since the age of 8. But as life goes on, her ability to actually repair and renew herself actually diminishes. Somewhere in the middle is a newborn human. And there's been lots of work, lots of interest since the 2000s, really, about the whole concept about stem cells and how we maintain this balance between repair and renewal. Unconstrained growth is otherwise known as cancer, but controlled growth and repair is highly beneficial as life continues. We know from there are two good species across the vertebrates. So one is the newt and also the zebrafish, which we know from experiments and from history that they can regrow limbs and they can regrow quite complex organs. So on the left we've got the newt, the humble newt, and we know they can regrow entire limbs, either if they're traumatized in nature or in a scientific scene. The zebrafish on the right, lovely, delightful, beautiful blue and silver fish, we know from experimental work that they can regrow parts of the heart, and they can do that without causing any scar tissue, which is very important. So there was once a dogma which was held for a long time, that we were born with a set number of cells. And as time went on, that cell population aged and eventually organ systems failed and you died. But eventually it came to light both visibly, we have hair, teeth, skin, which actually, which are very visible organs, which continuously grow and renew themselves. Also, for example, if you're a living kidney donor, the remaining kidney will actually scale up and take over the work to compensate. We know if you have a liver resection, the liver regrows by itself. And we know also if you have a narrow heart valve, part of the process where the heart adapts to that loading condition is by increasing the number of cells, which is due to recruiting the stem cell niche. So each organ system has this like a latent niche of cells, which just sits there ready to go. As you age, the ability for them to actually wake up and do some work actually diminishes. So, as I said before, as Michael mentioned before, our all-comer mortality rate is about 1.4%. There's a subset of the patients that we treat who are born with half a heart. So one of the pumping chambers is absent, and the right ventricle is the only side of the heart's pumping chamber which is available to pump blood around the body. In fetal life, the mother's nurturing the growing child via the placenta, but after delivery, the condition is unfortunately fatal. Of the parents who are counselled antenatally and who decide to continue with pregnancy and to embark upon staged surgical palliation, the mortality rate can be between 20 and 30% in the first operation. And this is just shown in the right-hand panel. If you look at the survival curve starting off at 100%, at the top left part of these curves, there's a drop-off. And so lots of the medical community racking our brains for many years about the best way of doing this operation and how to fine-tune the outcomes to try and get the best for our children who are referred to us. As I said, you can't immediately go to a definitive circulation which will last you into later life. So there's a series of 3 operations. The first one called the Norwood. When we reconfigure the heart, we take a supply of blood to the lungs, either with a little Gore-Tex tube off the top left-hand part of the aortic arch, or a ringed tube on the right-hand panel between the right ventricle and the lung arteries. And it's a very fragile circulation. Several months later, we'll do the second operation when we reconfigure some of the body's veins from the upper body to drain blood directly into the lungs. And then finally, between about 3 and 6 years of age, we'll do the final operation, which is a Fontan, which is a circulation whereby all your dark blue venous blood actually passes passively directly into the lungs without going through the heart. And then the pink and oxygen-rich blood returns to the heart and is then pumped around the body. The Achilles heel is the first stage, really. It's the condition, as I said before, is lethal if untreated. It's a very fragile circulation because if you're a red blood cell and you're in the heart, you've got a choice of going to the lungs or to the body. And it's a very tenuous situation. So we thought, how might we be able to help the heart's pumping function, either by increasing the cell number, by adding extra cells from elsewhere, or by stimulating the existing number of heart cells. People for many years have debated about the precise means by which it might take place. You either provide a chemical substance which stimulates the heart itself to pump better and to grow itself naturally. Others felt you could provide stem cells from other sources, for example, bone marrow or from skeletal muscle, by injecting those sorts of cells into the heart muscle. And there was a belief at one point these would be able to sort of transfer back into heart muscle cells. We were a bit sceptical about that in 2005 onwards. We felt very much it was a local effect because of growth factors, which was the most likely thing. If you go back to the later stages of pregnancy and fetal life, the growing baby is nurtured by the mother and the placenta, which is a really ugly, slippery, yet fascinating organ. It allows a immunologically different individual to be tolerated by the mother, who may well be a completely different blood group. It nurtures the child, and the blood circulation that passes around the growing child and the placenta is completely separate to that of the mother. There are these concept of cord blood stem cells which float around the baby, and these are highest in the early stages of pregnancy and then diminish with time. But effectively, each child is born with a concentrated supply of stem cells in the cord blood. And we speculated that we might be able to use that to try and improve the heart function. So some preclinical trials and some work was done in 2005 to 2007. And then my colleagues here conceived of a clinical trial, which would be first in man, and assembling a large panel of experts and securing funding from a range of sources, we were able to put this work together. So with the children who were identified and the parents were invited to actually participate, they were recruited and the cord blood collected at the time of delivery. That was then processed and kept, and then during the first stage operation, that was administered during the period of time when we stopped the heart to do a particular part of the reconstruction. So you're giving autologous stem cells back to the child in a purified form. And then 90 to 100 days later, before the second operation, they went through a process when they were imaged with an MRI scan to compare the heart function to some controls who hadn't had the stem cell therapy. We managed to identify 10 children who actually completed the cell therapy program. And these were then assessed just before the second stage. And these were compared to 22 controls. And the outcomes were a mild increase in the right ventricular function. And the results of this work have just been published in a journal. So we can see here the table here. The ones treated with the cord blood cells had a slightly increased ejection fraction, which is the proportion of blood which is ejected with each heartbeat, and some other beneficial volumes there as well. Because of the numbers, and it was not possible to actually do a control group directly, so we used historical controls. It was really a safety and feasibility study. So as I said at the very beginning, it was a first-in-man clinical trial. That the whole concept has been taken up also by a major American centre called the Mayo Clinic, who also have their own stem cell facility. And we proved that intracoronary delivery of these cells is both safe and feasible. I'd like to take the opportunity to thank the following bodies who supported this quite complex piece of work, without which we couldn't have done it. Thank you very much.
Right. Thanks, Ben, so much. I think everybody will appreciate just the incredible importance of research from that example, and get a real sense of the length of time that it takes often to get to publication or to get to get a clinical trial up and running. So thank you so much for that incredible presentation. Ladies and gentlemen, what I'd like to do now is introduce our two fantastic nurses. I'm going to introduce them both together, and one can speak straight after the other. So I'd like to introduce Dominic Morsman and Tressa, who are our two clinical nurse consultants here at the RCH, or two of our clinical nurse consultants. So Dominic's career spans over 20 years, spending her first 10 years in adult cardiac and critical care nursing at the Alfred Hospital. After brief periods working in London, she returned to Australia, where she worked as a NUM and bed manager at after hours hospital manager for St Vincent's Hospital in Sydney, before making the move to paediatric nursing in intensive care here at the hospital. Throughout her career, Dominic has worked with patients with end-stage heart failure, VAD, ventricular assisted device, and heart transplant. In 2017, she had the opportunity to work within the cardiology department as a clinical nurse consultant in this field. And then Tressa, who will speak after Dominic, has been a nurse for 12 years and is currently working at the RCH as a heart failure clinical nurse consultant. She obtained her nursing degree from the University of San Francisco and recently obtained her master's degree in advanced nursing practice at the University of Melbourne. Tressa moved to Melbourne in 2017, where she began her journey at the hospital, working in the paediatric intensive care unit. And in 2021, we're delighted that she transitioned to the heart failure team, where she now cares for heart failure, VAD and heart transplant patients. So welcome, Dominic, welcome, Tressa, and thank you so much for being here. We'll throw to you.
Thank you, Sue, for those interactions. My name's Tressa and this is Dom. We are part of the heart failure team. Firstly, we'd like to thank this opportunity to all of you guys for inviting us to speak in a way where we can explain what we do as a service and how we care for our kids. Before we start, I would like to paint a picture of one of our patients who came from New South Wales. Although every patient journey is different, she is a common pathway that we would see. So she had previously been healthy, and for a few weeks she had vague breathing issues and some stomach issues as well. So the parents thought that it was a mild viral disease. However, it didn't get better, and after a week she presented to the emergency room. In the emergency room, she deteriorated and she had a chest x-ray completed. Soon after, the x-ray showed that it was cardiomegaly, and with an echocardiogram, she was confirmed to have cardiomyopathy. A referral was made to our team, and she came from New South Wales to RCH, and we informed the family that their child is in heart failure. For some, medical therapy and surgical interventions can stabilize the patients. However, for this little girl, she needed support, like the heart VAD device, ventricular assisted device that you can see in the picture. And this will be her bridge to heart transplant. This journey is long. It comes with considerable risk, not to mention the complete disruption of the family's life of relocating to Melbourne and being away from their extended family and friends. While on VAD, the parents and the patient has no idea when they'll receive the call that a suitable heart is available to them. Some parents have described this experience as being in a limbo, just waiting. Sadly, some parents never will receive this call, and as their child passes away before a heart becomes available to them. Fortunately, this little girl received a heart transplant and she was discharged from the hospital, and we transitioned her care to an outpatient setting. From there, she integrated back into society, focusing on a good quality of life. Our team manages these heart transplant patients until they are transferred to adult hospital.
The workforce involved in a patient journey like this involves a cardiologist, a fellow clinical nurse consultant, and we were lucky enough that our manager, Caitlin, underwent her nurse practitioner and has now been operating a nurse practitioner role since January last year. And it takes all of us to care for these patients across this journey. Our nursing team has adapted over time to meet the needs of these patients and to cross-cover the entire heart failure service. back in 2017, the model was that we had a VAD CNC and we had a heart transplant CNC, and introduced a role to have one CNC work across both VAD and transplant. And since 2017, we've had an opportunity with some change in workforce and the introduction of the MP role to have all of our CNCs, which is about 5 of us now, to work across the full spectrum of end-stage heart failure, from that heart failure cardiomyopathy workup, a diagnosis like Tressa showed from the ED presentation, through to VAD, implant stage and post-operative care and ward care, through to transplant coordination, transplant care, both inpatient and outpatient at discharge phase, and to help transition those patients to the outpatient setting, to the adult services as well. This comes with considerable challenges. Sorry, it's a bit slow. It's important to highlight these challenges to understand, why our nursing team went to a more cross-cover workforce. We have increasing numbers of VAD and transplanted patients over time. With the introduction of VAD, we've had less deaths on our transplant wait list, and we've been able to improve those transplant patient outcomes as well as they go into transplant in a much healthier state as well. However, with that comes along hospital stay. Not only complex clinical care amongst that, but the psychosocial aspects of a long hospital stay for a family as well that may have moved here from interstate as well. The potential high morbidity and mortality for these patients. And our staff also need to adapt to the technology changes. And last year we had changes in both of our ventricular assist devices, our pulsatile devices and our centrifugal devices, and that means training over 200 staff that work across the wards and in PICU, and ourselves as well, and cardiologists and fellows and ward medical staff as well. And the transplant organ coordination itself is a narrow margin of error for that. And can be quite stressful. And also just managing patients, like Tressa said, that are a geographically dispersed patient population, because they can come to us from anywhere within Australia as well. You can see all the roles that we do within our nursing service. So amongst all the clinical care, from inpatient to outpatient and coordination, we're also involved in service development to help quality improvement projects, and also begin some research. And we've recently become a member of the Paediatric Heart Transplant Society registry that gives us access to what is happening predominantly in North America, but globally as well. And they're currently working on projects to standardise care of the transplant patient. We've been very thankful this year for the opportunities that philanthropy have given our CNC group this year alone. Tressa herself was able to go to ASIO in San Francisco. We've got 2 of our CNC and nurse practitioner are currently left today to go to the European Society Conference in Amsterdam. And myself and my colleague Danica will be going to the World Congress at the end of the week, which happens every 4 years. And we're very grateful for those opportunities, not just to improve our knowledge and education, but also to help us network and have conversations with others in our field as well.
As someone who has come into this role from last year, it was a big learning curve to know what it takes to take care of heart failure patients. Being able to go to these conferences allow me to learn about different hospital practices, new medical advances, and networks within our other CNC cohort. This would not have been possible if it wasn't for our kind and generous donor. From attending the conference in June, American Society of Artificial Internal Organs, I was able to reflect on our advanced current practices and what we do in RCH well. For example, in March of 2022, we successfully rolled out a new, more mobile and portable VAD device called the Berlin Heart X-Score Active. This device changed from being a 120 kilo machine with a 30-minute battery life to a small 14 kilo device with up to 10 hours of battery life. This has changed our patients' quality of life, allowing them to go have more freedom within the hospital. North America is still waiting on FDA approval currently for this device, which they need 40 patients in the trial to complete, and currently they have 35. We also rolled out another device called a HeartMate 3 as well. So going to these conferences allowed me to create interprofessional and international relationships where I was able to reconnect with my colleague that I work with at the Children's Hospital of Los Angeles. And that allows for future collaboration as well. I also have gained a lot of inspiration to give us more idea of what we can do, such as nurse-led research as well. And also to know that there's always room to improve our practices.
Again, through the opportunities of philanthropy, my colleague and I, Danica, after the World Congress, have the opportunity to partake in some observerships at Cincinnati Children's Hospital of Los Angeles, and Sick Kids in Toronto, and we'll spend a week at Sick Kids. And the table that we've put up here is just to show the different models of care and different workforce that different hospitals use. And what we're hoping to gain from this is a focus on our clinical outpatient transplant care and how we can improve our flow within our clinics, and also value add for our patients transitioning to adult services, to see how we can integrate what we can do at a primary care level with our transition teams, and to see where other centres like Sick Kids, who have really taken the lead in transition, are doing, how they're doing things. Canada's very similar geographically to Australia as well, so that's important for our patient care to gain knowledge in. All of these centres are part of the PHTS registry, and also Action Registry, which looks after their VAD patients, which we are hoping to join as well. So we're going to discuss with them how we work that into our workloads as well, and how they manage that also. And it's an incredible opportunity for us to be able to do that, and we're so thankful for it, and we wouldn't have that opportunity without philanthropy. Thank you.
Fantastic. Thank you, Dominic and Atressa. That was a fantastic presentation. I was just reflecting how it's a great example of what we've come to know and expect about all our nurses. It was a great exercise in teamwork. So thank you so much for that. It really showed us also, I think, how a great example of how the hospital is improving patient care through education and training. Just talking about some of those visits and observerships that you can do, really quite fantastic. So an enormous thank you to all four of you for the presentations and the incredible insight into the cardiology department, and I think showing us in particular just how much it takes to give great care, how important research is to developing great care, how important our nurses are alongside our cardiologists and our cardiac surgeons. It just shows what an incredible kind of teamwork it is. And I think what your presentations have also shown us is the incredible power of philanthropy. So thank you all so very much for that. It's been really, really terrific. Ladies and gentlemen, I'm going to introduce the Q&A section of today's event in just 1 second. A reminder, so that if you've forgotten, you can ask a question of any of our guests today. Just type your questions into the chat function. And please let us know your name and which panellist you'd like the question for, or all four. And so while you're sending your questions through, though, we have a very special video about Noah, who is one of the incredible patients who has been cared for by the RCH's Cardiology department. So we'll just run that video now.
Josh and I went to secondary school together.
I was about 19, got a job at the local ice cream factory, and worked on the same machine as Rhiannon, and she realised I wasn't a bad bloke. Ended up being married. She was 21 and I was 22, and our daughter Tanisha came along.
Perfect pregnancy, perfect labour, and then perfect baby.
We'd spoken about we wanted sort of 3 kids, and to have them straight away.
So we tried again, and then we did have a miscarriage. They reckon Tanisha was pretty much like a miracle to happen.
And then we had Noah, so 6 years later, we were able to have another child.
So we went into our 20-week scan, and You know, he's just scanning away, and there's this is the feet, this is the head, does all that, and then he was quiet for a very long time.
And Rhiannon and I were sort of looked at each other and were wondering, is everything okay?
And then I think he just said there's a bit of a problem with the heart. We went to see my doctor and she said hypoplastic left heart.
There wasn't too many people we knew who had gone through this.
Hypoplastic left heart is one of the more complex heart conditions that we deal with. And basically the left side of the heart hasn't formed properly. So most of us are born with two sides, a left and a right side. And in Noah's case, the entire left side of the heart hadn't formed. So he delivered at the Women's Hospital and then fairly quickly was brought across to our intensive care unit at the Children's, and then went for his first operation at a few days of life.
We had our little boy, Noah.
We both got a hold, and then they said, do you mind if we take him because he looks a bit blue?
Pretty much had to hand him over and leave him in the hands of all the doctors.
You're not meant to give birth and then not have your baby there. Yeah, so it's just hard not knowing what's going on.
You see him wheeled off, you've just got no power, you've got no control over anything.
Could be the last time we're ever going to see.
I knew his chest was going to be open, but not to the extent which it was, with drains coming out and so swollen. As much as you want to be able to pick your little boy up and just cuddle him and, you know, give him a good kiss and a good squeeze, we weren't able to do that. So any moment we were, give a kiss, and that was, pretty good moments. Utmost respect for all the nurses, the doctors. Our cardiologist has been brilliant. Bryn, our surgeon, Eves, is like just magic. Nothing in the world you could give to him, like, to thank him. He'll be turning 4 in May. Everything's going pretty well. So he's had 3 open heart surgeries, catheter procedures through his time. He's had stents and shunt put in just to keep him ticking over. Had his most recent surgery a month ago and he's bounced back brilliant. You just wouldn't know he's got the scars under the t-shirt to show what he's been through, but incredibly resilient kid. You look for heroes and inspiration. Well, mine's my son.
What an incredible family. Ladies and gentlemen, I'm delighted to say that Rhiannon, Noah's mum, has joined us today. Rhiannon, thank you so much for joining, and thank you so much to you and Josh for letting us tell Noah's story. We asked Rhiannon just how Noah was going, and I'm going to read that out to you because it's really pretty fantastic. Noah is going well. He was 8 in May and is in grade 2. He loves school and he is sports mad. He plays soccer and cricket and is an AFL fanatic. No doubt he's had a terrific time with the Matildas over the last little while. He always wants to be playing a sport, whether it's kicking footy outside or in the lounge room, to having a hit of cricket in the backyard or also in the lounge room. That's probably a bit scary, cricket in the lounge room. But anyway, that's so fantastic. I know you're having a look at some incredible photos of Noah and the family right now. So again, Rhiannon and Josh and Noah and the whole family, thank you for sharing the story with us. Okay, so now I am delighted to kick off the Q&A section of today's event. And while you're typing questions in, and I know there's been a lot to think about, I'm going to kick it off with a question for all the panellists, so we can just get things going. So, folks, since the first cardiac surgery was performed at the hospital in 1946, and that's pretty incredible to think about, isn't it? We've seen incredible improvements in the field, and you've all talked about those. What's a major advancement that you've witnessed or been a part of over the last decade? Maybe, Michael, I'll kick off with you.
In the past decade, I'd say our approach to looking after patients has changed. It is much more team-oriented. There's much more shared decision-making, not only with the families but amongst the craft groups. Not only our service, but I think medicine's become much less hierarchical, and I think that's a good thing. Because of that, quality has improved, and also, importantly, safety has increased. The ability to speak out and raise questions and issues when we're talking about looking after precious things is incredibly important to us. So it's just the style of medicine, I think, is the biggest change over the past 10 years. Technology's improved, of course, and we understand the way that the heart works a lot more. We've improved surgical techniques. But I think that's the biggest thing across all of healthcare, is the way that we practice medicine has changed.
Yeah, and I think it's interesting, isn't it, that at the same, that's kind of happened in parallel to an incredible new building, a new facility here at Flemington Road that was built to reflect what that new practice was going to be like. So so I think that's that kind of resonates, doesn't it? I think the way you framed that, I'm going to ask our two nursing consultants, two nurses, to talk a little, expand on that notion of how care's changed.
How care has changed for me is knowing that devices can change, because we've had the Berlin heart for almost over a decade, and then to find out we have an NextCore active device that's way lighter and gives more freedom for the patients and family. Our care has changed with that. And with that, our patients can go out on a day trip or can go to care by parent accommodation for the weekend. To be away from the hospital setting of the ward is kind of so simple, but so big for them.
Yeah, definitely leading on from that, I think the change in how we support our families from a psychosocial perspective and having that as a focus alongside the clinical has really developed over the 20 years that I've been nursing as well. And even just the last 2 years with what I'm quite passionate about, which is the transition to adult services. We know that a third of our heart transplant patients, the third leading cause of death for our heart transplant patients is non-compliance, and that happens quite often in the adolescent years, and how we can change how we approach every conversation with families of that age and with kids that age and families and really impact them from there onwards. But that I don't think would have been a focus 20 years ago.
Michael?
I was just going to add that I think Dom and Tress have been very modest about the way that the heart failure service has changed over the past 10 years. Prior to the introduction of our VAD service, we used to have about 4 to 5 transplant patients per year. We couldn't sustain the children for long enough whilst they were waiting. Now, the introduction of VAD has allowed us to support them whilst they're waiting. Within the confines of Australia and New Zealand, the number of donors we have available is relatively limited. But we're now transplanting or able to have about 12 to 15, sometimes 16, 17 transplants per year as a consequence of VAD. And the service, whilst it's still relatively small, if you think about the absolute numbers, in comparison to other sites around the world, we're actually quite a large centre for VAD. And so when we're thinking about the philanthropic support for people to go across to the US to learn things, it's actually a much more two-way conversation. We're able to share our experience of the XCore device, for example, because they haven't been able to get it in yet. We have, in some ways, we're more agile in getting new technologies in comparison. So that's been a huge advantage to us in the way that we practice, but also not only our standing in the international field, but what we can give back to the care of these children around the world too.
Yeah, great. Thanks, Mike. That's really, and I know we were delighted to support one of those early VAD devices that made that difference that Tressa was talking about in terms of young man being able to get home, in terms of him being able to move around. You know, that was we were kind of delighted to be able to do that and watch that change take place. And so philanthropy played a part. Ben, we've got a question for you about research. I think this is along the same lines, but specifically about research. Successful treatments for heart disease can take decades to research and develop. What are the advantages you're hopeful to see in the next 5 to 10 years?
So I think when we look at the care of children, as Michael's already mentioned, it's more nuanced. So over the past 70 years, when the first operation was done using the heart-lung machine in 1953, there have been big gains very early on. And like anything, it's now a mature field. So to try and continue to make small incremental gains is more and more tricky. And so the ability to interact with other professionals around the world and to share our knowledge and to try and get small incremental gains continuously is more of a challenge. And when you use the word research, I don't really artificially separate the two. So I mean, clinical care and also clinical improvement is still research in some shape or form. And then bench research in a lab, I think the two they actually complement each other. So there's a tissue bank here based at the Murdoch Research Institute, to which we contribute some of the heart muscle that we quite normally remove from hearts, which there's a team of researchers trying to identify reasons why heart disease develops. I think taking the stem cell theme, I think there are two broad categories. One is trying to improve and to stimulate the heart function. You can't change the hand that's been dealt in terms of structure. By the time a baby's born, you have to commit to a sequence to try and optimize that child's outcome. In terms of structural stuff, I think there'll be advances within 10 years with tailor-made bioengineering. So, in several heart diseases, we have to use artificial tubes to take blood to the lungs, for example. These are they're either polyester or they're human donor valves, and they wear out. And I think what we'll see is the ability to take personalised cells from a given patient and to seed scaffolds and to make durable tubing and valves, which will last a lot longer. And that I think it will reduce the burden of re-intervention for children, and so will reduce the number of procedures they have to have, taking a lifetime view of things. Yeah.
Great, thank you. And I think, it's interesting that you talked about you don't separate research from clinical care, and a lot of what we support and our donors support is, more at that translational end, translating care, care into new care practice fairly quickly. But I was also reflecting, how much both teaching and training, so how much, paediatrics has been part of this hospital from very early days, and how research has been part of this hospital for very early days, and then this last facility is kind of showing the real integration and what an academic health science centre can look like. And I think we're hearing that example in what you're saying as well. So we're very blessed, aren't we? So turning to Dominique and Tressa for a minute, it was amazing to hear about the success of the advanced heart failure services and the significant education and training opportunities which have been available to you, and we'll keep supporting you in that. Can you give us an example of something in your day-to-day practice that you wouldn't have been able to do without the specialist knowledge that you've gained?
For me, for my day-to-day time, is that our patients are so specialized, and with education and training opportunities, they're so important for our service. Like when we rolled out the X-Score Active Berlin Heart in 2022, we were able to get a representative from Berlin, Germany, to train us as a team and train the surgical team for fusionists. And then from there, we were able to train the PICU nurses and the other VAD nurses in Koala, and also the parents. So without the opportunity for training and education, we wouldn't be able to sort out these new devices to bring to RCH so we can present it to our families and patients. So it really keeps us engaged, very passionate, and know that there's more to change, that we are open for change and for innovation.
Yeah, great. Thank you. Thank you. And Dominic, anything to add?
Yeah, definitely. Exactly what Tressa said with the change in devices and being able to keep up with that as well. But also, you know, I was lucky enough to go to the World Congress last time, and even changing some of the anticoagulation management for our VAD patients and understanding change in drugs that we're starting to introduce the last couple of years, just to be able to benchmark that against what other centres are doing internationally and lead with that here as well. And also with the devices, you know, we've implanted one of the smallest patients for our centrifugal devices within the Asia-Pacific region as well. So to be able to take that back as well.
Yeah, great, thank you. And so, as you can see here, the importance of continuing development, and that doesn't go. That's not just in cardiology, but that's right across our entire staffing workforce, and particularly continuing to develop our nurses is such an important thing. So, ladies and gentlemen, we're nearly at the end of our hour together. I wanted Michael to ask you one final question. It's not a trick, but if a donor came... Yeah.
It's a trick.
It's a trick.
I know it's a trick.
If a donor came to us and said, we have $1 million for cardiology tomorrow, how would you use those funds?
You've asked me that question before, and you know I never give you a straight answer. And the reason why I can't is that I think it's so important that we not only support every element of what we do, but the three elements as we've tried to put out there today with the research, the education, the training of our people and the clinical care. We have requirements in all three of those spots, and it's very hard to favour one area versus another because they're all so important to the care that we deliver. I think that, you know, with the way that we interact with our donors, I feel as though donors particularly have a liking to one area versus another, and we're always welcoming to have that discussion about where they would like their money to go, because in the end it's their money, we're benefiting from it, our patients are benefiting from it, but it's their support that we're hoping to implement. So I think it has to be a two-way conversation there. It can't be, I want this and therefore I'm going to get it. Yeah. It's a discussion. Yeah. And I think that relationship with our donors is incredibly strong because of that.
Thank you, Michael. And I suppose, yes, it is a little bit of a trick question, but the reason we ask it, ladies and gentlemen, is really to allow the clinician or the researcher here to kind of think big, but also for our donors to feel about where you all fit into the picture as well. Not everyone's giving $1 million. Some people are raising $80 on the weekend in a lemonade stand for cardiology, but you fit in somewhere, everywhere, to the way we run our clinical care, to the care we give at the bedside, to the way we develop our clinicians and researchers and the sort of research we do. So yes, it's a bit of a trick, but it really is to show you how you can fit in. So thank you everybody on the panel. Thank you everyone for joining us online. That just about concludes our event, but I did just want us to reflect on something that I was able to see while we were watching the video that you all online couldn't see, and that is, and I think it's really reflective of just how kind of considered and heartfelt the care here at the RCH is. I looked at the faces of my colleagues over here, and you might think, well, how many patients do people see in a day, in a year? But I can tell you those faces were fixed in care and concern for Noah, in love for Noah on his journey, and Rhiannon and Josh. And so, if you had any shadow of a doubt, our clinicians, our nurses, our researchers are all, there with their patients in a very heartfelt way every single day. And of course, I can say that about our passionate supporters as well. You've joined us this morning, but you'll join us on an incredible journey to support cardiology here at the hospital, to support research at the Murdoch Children's Research Institute, to support teaching and training with the University of Melbourne Department of Paediatrics. You're helping us on that journey. You and the people who've gone before you have been helping us on that journey for the last over 150 years. Philanthropy is so incredibly important to everything that this great hospital is and does and has been and will continue to be for into the future. So if you've been inspired by today's event, and we know you have been because you're part of that journey and you're part of our foundation family, we'd love to help you continue to make an impact in cardiology, whether that is, as I say, raising funds on the weekend or through your community, all the way through to leaving a legacy in your will. We'd love to hear from you. I think we're probably putting our team's details in the chat right now, so please be in touch with us. For those of you who are joining here at the hospital, we'll be with you in a minute in our offices. Other than that, ladies and gentlemen, thank you so much for your ongoing support. Thank you for everything that you do for these incredible people who are working for your children and your children's children. And with that, we'll sign off. Thank you, everyone.